whole thing was amazing, and because I've been doing the healthy eating. Well, no, it's because I've been doing the healthy eating.
Goths, yeah.
You know that's once. I got to have a cheat day at the Chinese place, so
it was fine.
It wasn't like I eat that way all the time.
See, that's the thing about the lifestyle that we're promoting. That it's made to do that. You found yourself in a connected environment.
Yes.
With great people from different parts of the world.
100%.
Internet restaurant that they love to go to, which is a, say, quote unquote, delicacy hole in the wall concept, highly regarded.
Yes, exactly.
Right? For the New Yorkers.
The wait was
not
incredible.
Not a touristy place.
Not at all.
Right. Locals, which are usually the better ones.
It was mostly Chinese families
Asian
celebrating
families.
Some kind of big holiday.
They have a new year every month. Right?
No, it was like a birthday or one person's anniversary.
Right.
Like it was the place they go to when they want to celebrate.
Correct. So here's the thing. You can do that because 80, 90% of the time, you're staying within certain boundaries.
Right.
On a variety of foods that may be, deleterious to you, depending on your genetics and what position in the spectrum of your health life you're in.
So, hi, everybody. I'm Davio Venturis. I'm the host of the Leverage Podcast. I'm here, as always, with our esteemed cardiologist, Dr. Federico Macy, otherwise known as Dr. Suave. Very excited to have you guys on here.
Good to see you again.
So, what I wanted to ask you, since we've been talking about this trip a little bit that I just took. The hot thing now, because my godson's family they're in the fashion industry, the photography. She's kind of a big time agent. He's a big time retoucher, and they're in that world. And everybody in that world is on the Wegovy, as they call it.
Wegovy, they call it.
Yeah, they're on the. Are you on the Wegovy? I mean, that's the brand that's there.
Right.
Here in Texas, it's more. I hear Ozempic.
Right.
I want to. You're Dr. Suave. You're got your ear on the train tracks of the pulse of what's going on. Can you shed some light to me? What's going on? Why is everyone so excited?
Right.
It doesn't get you high like cocaine, so why is everybody on the Wegovy?
Right. Well, so Wegovy or Wegovy and Ozempic have the same molecule. So.
And what is that molecule that they?
Semaglutide.
Semaglutide. Okay.
Semaglutide. Right. So the pharmaceutical company that makes it labels one for weight loss and the other one initially for type 2 diabetes.
Okay.
So
how long have we known about the semaglutide?
Well, the main landmark study was published in 2016.
Wow. Recent.
November 2016. So we're talking now almost 7 years ago. And that study was called Sustain 6.
Okay.
Sustain 6. So that study was roughly 3,300 participants in 20 countries.
Okay.
Pretty impressive, right? So multi-country study.
And they were looking for a diabetes drug?
Yeah, so they were looking for cardiovascular event reduction.
Okay.
So they took 80% of the people had type 2 diabetes or renal disease already in the study, average age in their 50s, followed for 104 weeks, 2 years. So it's a 2-year study. And they were given, half the people randomized.
Right. Double blind.
Placebo
blah, blah,
controlled.
Right.
So it was very well conducted, right? And so they were given starting with a low dose and then a higher dose, 0.5 milligrams and all the way up to 1 milligram. Okay. Once a week. So it's an injection that people put into their abdomen once a week. Okay. And again,
what happens if you do it more?
Well, that's not the way the study was conducted.
Okay.
It was just once a week. That's the way it's indicated.
Okay.
So basically, the primary endpoint after 2 years was to see who had less cardiac death, whether the placebo group versus the ones who were on the Ozempic, on the 0.5 or 1 milligram once a week, less heart attacks, less stroke. So it's called a triple major adverse cardiac events, triple endpoint. So whatever occurred first. Okay, so
why is it called a triple endpoint?
because it has you can meet the end of the study by achieving either by dying
Okay.
or having a non-fatal heart attack or non-fatal stroke. So that counts as an event.
Right.
Okay.
So you're a failure in.
Well, no, you've had an event.
Right.
Because the doctors don't know who is getting the drug, and the patients don't know if they're getting the drug.
Right. Double blind.
So they had baseline characteristics that were the same.
Right.
Very well, about half women, half men. Right. So
20 different countries, so they could do different genetics.
and different, yes. So cutting to the chase here, there was a 24% reduction after 2 years of using it in the primary endpoint, the triple endpoint.
Wow.
Deaths, strokes that were non-fatal,
That's
heart attacks.
That's a huge reduction for a drug, correct?
If you look at them separate, remember, it was only 2 years.
Right.
Look at them separate. Okay, so 2 years is a short time for cardiovascular drugs.
Right.
So initially, this was labeled as an endocrine drug for diabetes. Now we know in retrospect that Ozempic or Wegovy, parent molecule semaglutide, is really a cardiovascular drug.
Okay. And how does that? What's the mechanism? What's going on with this?
I'll go into it in a second.
Okay.
Let me give you the rest.
Okay.
So the primary endpoint, 24% reduction. Okay. Strokes, 39% reduction in strokes.
That's
39.
incredible. That's incredible.
Yeah, 24% reductions in non-fatal heart attacks. That's where the difference was. It wasn't the deaths. It was the decrease in non-fatal strokes and heart attacks.
Okay.
Mainly strokes.
Which damage you.
That was called Sustain 6.
Right.
In addition, they observed 5 to 10 and up to 15% weight loss during the study, which is great for type 2 diabetics because they then experience better control of their metabolic parameters, hemoglobin A1C, blood pressure, and their cholesterol parameters.
So you're supposed to be in certain parameters and allow them to be better in their parameters because they'd lost the weight.
The weight loss was significant.
Okay.
15%
is a lot.
Yeah, anywhere from 5 to 15%, right? So behind that study came another study called Surpass with a different agent called tirzepatide, made by a different pharmaceutical company. And that study, again, over 4,000 individuals, followed for 72 weeks, so a year and a quarter, showed almost a 20% weight loss.
So how come I haven't heard of this semaglutide?
Yeah, it's called Mounjaro.
Oh, Mounjaro.
It was just approved in April or so of 2022.
And what does Mounjaro do different from semaglutide?
It's got an extra molecule that inhibits gastric emptying, so you get full very quickly.
So which one is better to take?
So Ozempic in general, after 1 year or so,
Right.
1 to 2 years, you get about a 15% weight loss. With Mounjaro, about a 20% weight loss of your excess body weight. So
when do you indicate to do one or the other?
well, it depends on which one your insurance company pays for. Some insurance companies pay for one, others.
Oh, really?
Yeah. But Mounjaro is, again, approved by the FDA for type 2 diabetes, not for obesity.
Okay.
Semaglutide is approved for both
Okay.
diabetes and for weight loss. So Wegovy, weight loss.
So if somebody doesn't have excess weight, they shouldn't be on the Wegovy.
Correct. On either of these. Okay. So they both lower hemoglobin A1C by 1 point or a little bit more. Mounjaro was a little bit more. But we know that lowering hemoglobin A1C is important, but it doesn't correlate with mortality.
Okay.
So what you really are after with these drugs, and by the way, they're called GLP-1 receptor agonists. So these receptors we have in our bodies. You have them, I have them, naturally. They're throughout our body, in our brain, in our heart, in our lungs, in our gastrointestinal system, in our pancreas.
And what do these receptors
muscles, and in our in our gut.
And what do these receptors do?
So these receptors, they're called G-coupled receptors. When they are activated through a series of downstream events inside the cell, they promote the release of a hormone, or it's called incretin, weird name, called GLP-1. And GLP-1 goes to the brain and activates the brain and improves vasodilation And in animal studies in rats, it improves memory and spatial orientation, and it decreases the deposit of a harmful protein called beta amyloid. That's just in the brain.
So is this the chemical that's in the semaglutide, or is this what the semaglutide causes your brain to release?
So semaglutide is called GLP-1 receptor agonist.
Right.
So it stimulates the GLP-1 receptors, and then those send out the GLP-1.
So it gets you to release more GLP-1.
Correct.
Which has only positive benefits.
Correct. Only positive. So that was a level of the brain. And again, we saw this in animal studies.
Wow.
These positive events at the level of the brain. The level of the heart, the upper chambers of the heart are called the atria.
Right.
The bottom, the ventricles. The atria have 6 times more GLP-1 receptors than the ventricles. So more in the top.
Is that because is the ones on the top the ones getting the oxygen-rich blood?
So yes, the blood comes back oxygenated from the lungs into the left atrium. The left atrium is more compliant, so less arrhythmias, like atrial fibrillation.
If you have enough GLP-1.
The more you release of it.
Okay, great.
Now, remember, the half-life of GLP-1 is only 3-4 seconds. So you have to be making it all the time.
So why isn't it helpful for people that aren't obese that get this drug? It sounds like it would be helpful for them too.
Yes, so that study is ongoing in a second. We'll talk about it.
Okay.
Okay, we're going to talk about it.
Okay.
So most people who are not type 2 diabetics, who are in good physical condition, have a lot of GLP-1 receptors.
Right.
And are producing GLP-1 continuously. So at the level of the brain also, at the hypothalamic satiety center, they tell you you're full. They take your hunger away.
I never had that drug in my body.
GLP-1 can be low in certain individuals, especially when they gain weight and become pre-diabetic or diabetic. You have fewer of the GLP-1 receptors, hence less GLP-1. Plus, you have more of a protein enzyme that destroys the GLP-1 called DPP-4.
So what about when I was skinny?
Yes.
But still never felt full and could just eat 2 extra large pizzas and a 2-liter of Coke by myself?
Well, that's because you weren't stimulating your satiety center early enough. There's a genetic component to that, and there's a learned behavior. It's both.
Right.
And other hormones play a role in satiety. This is only one.
Okay.
Only one of several. Right. You may have upregulation of the ones that increase hunger, that tell you to eat more, and downregulation of the ones that say, stop, you're full. Yeah. GLP-1 is about one that plays a role in, hey, you're not hungry.
Right.
Just one. Right. So going into the mechanism of action at the level of the heart, it helps the heart be more compliant, pump better, and less prone to supraventricular arrhythmias, the arrhythmias that come from the upper chambers, like atrial fibrillation.
Right.
We're seeing that. At the level of the gastrointestinal system, it slows down gastric emptying. So when you eat a little bit of protein, size of your palm, vegetables, the size of your 2 palms, right? You feel full quickly.
Sure.
Okay? So you may get some nausea. That is the main side effect with these drugs, with the Wegovy or the Mounjaro or the Ozempic, right? Because slowing gastric emptying means the food hangs out there longer, and so you elicit the nausea reflex if you try to overeat. So you learn quickly to not overeat. In other words, you control your portions,
right?
Which is a problem for a lot of men.
Well, that's why it helped me so much.
Correct. And so at the level of the pancreas, it helps those islets of Langerhans where the insulin cells are, right, secrete more insulin to get rid of sugar. And at the same time, suppress the other cells, which increase.
But isn't it bad
glucagon.
To have too much insulin? Doesn't that create insulin resistance?
If you have a problem with the receptors that the insulin can't engage.
Oh, and that happens when you have too much fat.
And when you have
because it makes those long chain.
Too much fat inside the cells stored, the long chain fatty acids inside the liver.
We discussed this in a previous episode. And that's
increases insulin resistance. So this helps your pancreas also maintain its Langerhans cells. Some say that it actually is neogenesis of the beta cells, so that you regenerate them, you produce more of them.
Yeah, neogenesis, that's a Greek word.
Yes, and prevent the apoptosis, the natural death of those cells, so they last longer. Because in diabetics, by the time you become a type 2 diabetic, you've lost probably 80 to 90% of your beta cells.
Wow.
Yeah. You're only working on a few.
Is it possible to get those back?
Some.
If you flip.
There's evidence that the GLP-1 receptor agonists are able to re-engineer, again, neogenesis of those beta cells in the pancreas.
Oh, okay.
So it maintains the integrity of your pancreas.
Is this a wonder drug?
Yes.
But only for people that
I will go through the indications in a second.
Yeah.
Okay? So in other organs, it at the level of the gut, in the large bowel, it activates those GLP receptors are coupled to these they're called L cells.
Okay.
And those form the actual GLP-1. So GLP receptor is like a 63 amino acid receptor, complex molecule that's on the edge of the intestinal cell. So there are bacteria when we eat fiber, when we eat vegetables, non-digestible fibers are good bacteria, Bacteroides and Lactobacillus and other good bacteria, ferment that fiber and form what are called short-chain fatty acids.
So that fiber is actually, even though we can't digest it, it's actually good for us.
The good bacteria, in other words, the probiotic good bacteria, ferment it, form 3 short-chain fatty acids, acetate, butyrate, and propionate.
That's why it's important to
eat vegetables.
Eat vegetables.
Every day.
That's why.
Not much, every day.
That's why you're all so into vegetables.
Yes. And so when you make those short-chain fatty acids from the non-digestible fiber by the good bacteria,
right?
And the more good bacteria, the more you make, those stimulate the GLP-1 receptor in the L cells, which release GLP-1 into your bloodstream, going all over your body to tell you you're not hungry. You paralyze or delay gastric emptying, so you're full already. Don't overeat. Got it? So
it's not just the semaglutide. It's semaglutide combined with a more vegetable-rich diet. Is that
yes, correct? So it's a comprehensive program.
Got it.
That really is what helps. This is why the Mediterranean diet is so good.
Just doing the injections isn't going to be enough.
And then eating crappy food and taking an excess of sugars, like liquid sugars.
Well, I always had a healthy diet. I just couldn't stop.
Right.
And this...
You didn't have the satiety.
Never.
This gave you the gastric emptying delay.
Right.
They gave you the early satiety, and then the extra signal at the brain to say, I'm full.
Right.
And the early satiety, there's a signal, the axis between the stomach and the satiety center in the hypothalamus saying, enough. You activate a receptor called alpha or melanocortin 4 receptor, which is the one that says stop.
You're such
eating.
A nerd. You're such a nerd, Dr. Suave.
Right? So,
you know every single one of these.
Well, there's a whole pathway because in addictions is the same.
Right.
So semaglutide does all of these good things. The actual GLP-1 is a 30 amino acid incretin hormone.
It sounds to me like semaglutide, Manjaro, and nitric oxide are
wonderful things.
Are the unsung chemicals that are going to
are helping
bring in like a new age.
So interestingly, a recent article out of Oxford, published in February this year, looked at the price point of these drugs.
Right.
Like if you go to a pharmacy here locally in the U.S.,
it's like $1,000 a month.
$800 to $1,400 depending on the state.
In New York, it was $1,200.
Yeah, $1,200. Okay, for 1 month.
Right.
1 month.
Right.
Okay. Most people need at least 90 days of this. And again, let's go to the indications in a second. What I want to say is the study looked at the cost of production of these drugs.
Is it expensive to produce?
$40 is what they came up with. So the point is there are basically 3 oral medications to produce fullness or to create a sense of fullness.
Satiety.
And decrease hunger, satiety, right? And 3 injectable ones. So among the injectable, we talked about Ozempic or Wegovy being the same because it's the same molecule, semaglutide. Mounjaro has tirzepatide and something called GIP. Okay, so
you know me.
Gastric inhibitory peptide or glucocentric insulinotropic polypeptide, GIP.
Do you not know which one it is, or is it both?
You can it's one or you can name it's the same one.
Oh.
You can name it gastric inhibitory peptide or glucocentric. Oh no, yeah.
So it has both.
Insulinotropic.
It has both those
polypeptide.
meanings.
Yeah, GIP
Okay, cool.
and GLP-1.
It's the GIP.
GIP, right. So those, and then there's another one called Victoza, is the brand name, or liraglutide. Liraglutide was the first out of the box in the group of GLP-1 receptor
But it's
agonists.
not as good as the.
You have to inject it every day, that one.
It's
You
not
asked
as-
that question earlier.
Yeah, it's not as good as semaglutide.
Correct. It doesn't have as good data, but it still does inhibit your satiety center. And that has remained more of a diabetic drug. These two are more cardiovascular drugs, and I'll mention in a second what's coming at the end of this year and next year with both Ozempic or semaglutide and the Mounjaro or tirzepatide.
In your opinion, is this going to end the obesity epidemic?
No, not even close. So the investigators out of London, England, right? And some colleagues of theirs in South Africa came up with these drugs are so good at battling the number one cause of death worldwide. Obesity, diabetes, cardiovascular disease, strokes, heart attacks, congestive heart failure, because of the obesity epidemic and diabetes, right? We expect to have over 700 million diabetics within the next 5 years worldwide. Over 700 million. Probably
That should be cheap.
double the number of pre-diabetics. Double the number of pre-diabetics. It affects minorities more than the Caucasian Western European populations.
Right.
Because of predisposition, genetics going back 10,000 years or more. Okay?
Right.
So their point was we should make the oral medications such as phentermine and topiramate and orlistat, and there is another oral medication that we use for weight loss, which is a combination of naltrexone with bupiprion. So
why do those drugs not work as well as the semaglutide?
well, they work. It's a 5% maybe,
but not
on a
24,
good day,
not 15.
not 15 to 20%.
Right.
Correct. And once a week injection. So these are still expensive. The cheapest one being phentermine, for example, which in their opinion...
Doesn't that have side effects, like serious side effects?
It can. It can have elevation of blood pressure, palpitations, insomnia.
It's kind of like speedy,
anxiety.
right?
It's speedy, yeah. It's a methamphetamine. It increases your catecholamines.
And that reduces your dopamine, doesn't it?
And
doesn't that lower your dopamine levels?
Well, the catecholamine, the acetylcholine effect, suppresses your satiety center. So...
But with all these other
and the
side effects.
amphetamine, these are cousins of Adderall, this one, right? Which is the methamphetamine. So this is why a lot of young people take it, because I get more focused, but also I keep my weight down.
Right.
Because they inhibit the satiety center. They tell you you're full.
Right.
Right? So the price point of these is a bit high, all of these. As I mentioned on the GLP-1 receptor agonists, $1,000 or more a month.
Right.
So their point was, shouldn't they, meaning the pharmaceutical industry that makes these, make these really cheap and available, so all of a sudden the whole world can take them?
Right.
Or people that need. So who...
Well, it sounds like most people in the United States need this drug.
So who are these indicated for? People who have...
Are obese.
Body mass index more than 30.
Pre-diabetics.
Right?
Obviously diabetics and worse.
And the indications have gone down to a body mass index of 27 or higher, as long as you have one or more pre-existing conditions.
Right.
Or BMI more than 30 with, pre-diabetes, diabetes, hypertension, dyslipidemia, so metabolic syndrome. We've talked about metabolic syndrome before, that pentad. So, in minorities in the Latino population, 36, 38% have metabolic syndrome in the US. Native American population, same. Okay? African American population, probably about 30%. Caucasian population, 24, 25%.
So at least a quarter of the country should be on this drug.
On average, 30%. Right.
This is going to be the best-selling drug of all time.
Correct. For sure. No doubt.
But why do you think it's not going to make a dent on the obesity epidemic if it is so effective?
Because this is just one part. To really optimize health, and especially obesity, and prevent the complications that come from it, you need a comprehensive program, starting with nutrition education, access to high quality foods that don't have chemicals that are deleterious for you, optimizing activity programs so people are active at least 30 minutes 5 times a week or more. You have to start with that.
Right.
It doesn't replace it. No drug is going to overcome poor nutrition and sedentary lifestyle. You can't take these forever.
So the reason it was so effective for me is because I did all
Yeah.
3 legs of I took your advice.
You took a comprehensive approach.
Right.
You optimized. You had a reasonable diet, but you optimized it.
Well, I was eating too much.
Correct.
Even healthy food, too much healthy food is bad.
Correct. You
Right?
can still eat too much protein.
Too much protein, it turns into sugar.
And you can turn into sugar. Right. So you have to keep, 1.5 grams per kilogram per day. No more, certainly no more than 2 grams per kilogram per day. And on the sugar, on the glucose, I prefer to stay under 40 grams per day. The American Heart Association says 36 grams per day for men, 26 grams per day for women for refined sugars, right? So you got to control those.
Right.
So you optimize with the vegetables, with the fiber that I mentioned, with all the gut benefit effects.
Well, it's always funny because every time you ever cook, it's the veggies. I'm going to make some veggies. And
Lots
it's a
of
joke,
veggies.
but now that you explain how
Yes, you have to
the
do it.
bacteria breaks down the fiber, and that's so important for all these reasons that you just explained, now I understand why you're so obsessed with veggies.
Yes, and a little bit of fruit.
Right.
So the point is, no drug is going to overcome bad behaviors, especially in the preteens and teens.
Right.
So we got to start early with nutrition education in kindergarten and going forward.
If only somebody had a book series for
There
children.
you go. Yes, the Eisenhower book series. Look it up, Amazon, Dr. Fred's Adventure. But anyways, that is part of what we do. So giving somebody a medication like Ozempic, okay, let's say
The Wegovy, as they say in New York.
Let's say they have insurance that pays for it and so on and so forth. You have to really be disciplined about it. It's an opportunity for you to reach your goals. And that's the way you should look at it.
Well,
And there are other side effects. So, by the way, we haven't gone over all of them. You can
okay.
get, constipation. Some people get diarrhea, severe abdominal pain. There is a small chance of pancreatitis, very small chance. So if you've had pancreatitis, you shouldn't take this.
Right.
There's a very tiny chance of medullary carcinoma of the thyroid or MEN2 syndrome, which is a type of endocrine tumors. I'm not going to get too much into it. They are rare, but they are there.
Right.
Cannot be ignored. Or prior allergy to semaglutide or tirzepatide, right? I'm not trying to be pharmaceutical rep here, but there are side effects. This is why someone needs to understand who you are.
So people shouldn't
explain
just take this. They should do this under the care of a doctor.
Correct. Under supervision.
Somebody who knows,
Yes, of course.
can look at your levels and say,
And then what's
this
the
isn't
right
good for you.
dose for you? Where
Right.
do you start? How often you increase it? So, for example, Ozempic.
You gave me a very small dose
Yes.
and not for long.
And that was great for you.
Yeah, it was great.
Didn't need to go up.
The habits that I built while I was on the drug have carried through
Correct.
because
and so
my stomach's. I just don't need to eat as much.
correct. You are on a successful pattern of now having achieved a large degree of behavior modification. You're in the maintenance phase without the medication after 90 days.
Well, I just don't have the cravings like I used to.
Perfect. Correct. Your dopamine levels come up because you're optimizing your activity program as well on a daily basis. Your diet, your personal issues have improved, and so your dopamine level is at a better rate. You're not looking for quick, high dopamine opportunities.
Sure.
Right? That only exhaust your dopamine production and so on.
It's a paradox.
Yeah,
When
so-
you go for those high dopamine.
Yeah, you end up
events.
injuring yourself and creating more anxiety,
Right.
depression, and then behaviors that are deleterious.
It spirals.
Spirals out, right? So including addictions, both to drugs and to other behaviors, including alcohol.
And not me personally. To
There
be
you go.
clear to the audience, I've
Yeah. So-
never had an addiction
So
problem.
the what's coming, which is very exciting, is that there is a trial, again with Ozempic, on non-diabetics who are obese. And it's a 5-year trial. It's going to be published, I believe, later this year. And with about almost 17,000 patients followed for 17 years. They don't have diabetes.
Right. They're just fat.
It's a cardiovascular outcome trial and diabetes prevention trial. So they're going to count versus placebo which ones develop cardiac events, the placebo group or those on Ozempic, and which ones develop.
17 years they've been following.
No, 5 years.
Oh, 5 years. Okay.
17,000.
Oh, 17,000 people, 5 years. Got
Yes. And then on the Mounjaro side, there's a trial that will be published next year that's called Surpass. And that one will be a cardiovascular trial. Again, the three major endpoints: cardiac death, non-fatal heart attacks, non-fatal stroke.
That'll be exciting to find out what happens.
Yeah.
What happens with Mounjaro and Ozempic together, Wegovy together?
No. You're
'cause it's the
activating
same-
GLP receptors.
So it's the same thing.
Same thing. Okay. So I think the Mounjaro, because it has two molecules, it perhaps delays gastroemptying a little better.
So
and that's why people lose that extra percent.
You like the
in
Mounjaro
weight.
better?
No. I like both.
Okay.
It really depends on the trials.
Got it.
Okay. And right now, Sustain 6 has cardiovascular outcomes. 24% reduction in the composite.
Which is how you got involved with this.
Yeah. So 39% reduction in stroke. So if I see a 50-year-old guy, type 2 diabetic, who has hypertension, bad cholesterol, obesity with a BMI more than 30, Ozempic is a great medication for them, especially because I have data to say I'm helping you over a 2-year period decrease stroke and heart attack.
Right.
That's a huge amount, especially if they've already had an event. So that's called secondary prevention. If they already have atherosclerotic burden, plaques in their carotids, coronary calcium score, meaning they have plaques in their coronary arteries, or plaques already in their iliofemoral system.
It'll help reduce the plaques?
No.
Oh.
No.
But it'll stop it from increasing.
It will hopefully prevent progression. Along with other medications, you have to lower the cholesterol. You have to control blood pressure. You have to optimize the diet and exercise.
So a lot of people know that what diet they need to eat. Obviously, I always did.
But staying with it is the difficult part.
Except for on the semaglutide. Yeah,
helped you a lot to be more compliant.
It became easy. Right. Well, I was full. I didn't want more.
So the fear people have, of course, is if I go off it, am I going to go to bad habits?
I didn't.
This is where the relationship with your doctor, the connection with your provider is so important to gradually, over those months, discuss eating healthy, activity that's consistent on a regular basis, and embracing those behaviors and partnering up with people who are on the same plan.
Right.
Like, you and I get together to go walk and we talk during our walk.
Or when we eat healthy food with
and
a lot of veggies.
Right. There you go. That is feeding the positive connection, the endorphins that come from the oxytocin that's released from those connections, and the positive reinforcers that allow you to maintain that discipline over time. And should you slip, then go back to your doctor and have that discussion.
Right.
No one's perfect. You can slip and say, okay, I'm going back to bad behaviors. I need a little help.
That late night pizza in New York, Saturday night at Joe's.
I'm sure it was wonderful. But one slice.
Yeah.
Not the whole pie.
Right, and not
This
something I
size.
do on the regular basis.
Correct.
Well, it was a big slice. It's New
It's
York,
the 80-20 rule. 80% of the time you're doing it right, 20% you have some liberties. But you've learned how to curve those too.
So, are we going to put a link in the below so people can, if they're interested in finding out more about semaglutide, if they're in the 25% that are indicated to take it,
yeah.
so they can find out more and maybe.
Yeah, sometimes insurance pays for it. So talk to your provider and see if you meet the criteria. Again, Mounjaro right now is for type 2 diabetics. Semaglutide is for both type 2 diabetes and those who are just obese.
Right.
It's
Or pre-diabetic?
Yes, if you have obesity as well. Of course.
Perfect.
So I'm, as a cardiologist, this is a cardiovascular drug that's got brain effects in a positive way. It has cardiovascular effects, as I mentioned. It's got gut effects that are wonderful because you're stimulating the GLP-1 receptors. If you eat more fiber, you're going to increase dramatically your GLP-1 floating in your bloodstream.
Great.
Because again, it only lasts a few seconds, so you need the constant production.
Sure.
Right? So optimizing your biodome, the good bacteria.
Well, I think that's
great.
I think that's a good topic for another podcast.
The biodome. Yeah.
Well, this is. Thank you for telling me so much about this, Fred. Yeah. It really was amazing how it's starting to become like really hot. I remember when you first told me about this.
Yes.
Months and months and months ago.
You ignored me.
Well, no, I didn't. I used it.
Well, eventually.
Yeah. But now to hear people just. It's like what they talk at parties. It was kind of. So I'm glad that you gave us a straight skinny. Everybody, once again, this has been the Leverage Podcast. Davio Venturas,
Dr. Macy,
Dr. Macy, Dr. Suave. Please follow us on YouTube, like and subscribe, hit the bell. and you can also share it. We're on Spotify. You can rate us on Spotify, share it as well. We're on Instagram, Facebook, TikTok, Twitter.
And others, I believe.
And that's fascinating, Fred. I think I'm exciting because
You know what's amazing? One last thing. I know you tell me not to say one last thing.
You always say one last thing.
No, because you use the 0.25 milligram injected subcutaneously once a week.
Right.
On Wegovy, we're supposed to go up each month all the way to 2.4 milligrams.
But I never needed it.
Exactly.
Right.
This is why the supervision is important. Where are your conversations?
Instead of just
and then you get
following.
sick, or you have side effects, or you fail for other reasons because you're not doing a comprehensive program. Anyways.
Right. Great. Thank you so much, Dr. Fred.
Till next time.
See you guys.
See ya.